We have a lot of information tonight. I really thank everybody who's come out. This is an important subject. I welcome everybody to tonight's public forum that's hosted by the Joint Committee on Mental Health and Substance Abuse, of which I'm a member. My name is Randy Hunt. I'm the state representative in the 5th Barnstable District. And the problem of prescription drug abuse that we face has overtaken by huge numbers the problems that we face with illegal drug abuse. Just one statistic. The Centers of Disease Control in Atlanta estimate that about 7 million people in the United States are using opioid drugs for non-medicinal purposes. 7 million. About 1.5 million, they estimate, are using heroin and cocaine. And the number of overdose deaths due to prescription drug abuse outweighs the number of deaths from illegal drug use by a big margin these days. Over the last 15 to 20 years, since 1990 essentially, things have started to change. And now we see that the biggest problem that we deal with these days with drug addiction is all with prescription drugs. We are calling our forum tonight Evening of Solutions, and the reason for that is we should not be discouraged, not at all. We have ways to deal with this. We need to change our thinking, and we wanted to bring to everybody tonight some information on new things that we're trying to do, legislatively, from a treatment standpoint, as well as the groups that are forming to support people who have addiction problems, as well as people who are in the close families of those, because they need support as well. Now, a couple of things before I introduce the panel, just so everybody understands. A couple of housekeeping items here. There were reports of this being a public hearing in a couple of publications. It's not a public hearing of the committee. It's a public forum. It's a public outreach effort by this committee. Because of that, I want to tell you that the bill that we're going to be talking about tonight as part of this presentation, Senate 2125, is in the House Ways and Means as we speak. It has passed the Senate already. And if you would like to urge the House Ways and Means to move on the bill to get it eventually to the floor of the House, I encourage that. And I will be sending out an email message to everybody who has signed up on my email list for this joint committee, information on how to do that tomorrow morning. A second thing is, since we have a great deal of information we're going to cover, we have made cards for you to write down questions on. It just is not going to be effective in using our time to have a question and answer live session. That was my judgment. However, if you have a question, my legislative aide, Suzanne Kelsch, is down here in the corner. She'll take a position where she can see you, and if you'll wave her down, you can get a card from her, and she'll pick that up and bring it up to me. Any questions that we have that we may run out of time by 9 o'clock and not have answered, we will still, I will give those to the panel, and we will, again, send to that email list the questions and the answers that we got. So if we don't get to everything tonight, we certainly will. Now, at this time, I'd like to introduce the panel to you. Will Luzier, and this is going from nearest to me down the row, he is Executive Director of the Interagency Council on Substance Abuse and Prevention. Chaired by the Lieutenant Governor, this group of agency heads meets quarterly to coordinate efforts in the arena of substance abuse. And I have the pleasure of being the minority party representative on that important council. Next to him is Michael Botticelli, who is the Director of the Bureau of Substance Abuse Services at the Massachusetts Department of Public Health. And he has been nominated to serve as the Deputy Director in the Office of National Drug Control Policy in Washington, D.C. Congratulations on that. Yeah. That is what you call a big deal. Liz Malia is the House Representative. Well, I'm skipping over John. Let me back up to John. John Keenan is the Senate Chairman of the Joint Committee on Mental Health and Substance Abuse, whose Senate district includes Abington, Braintree, Holbrook, Quincy, and Rockford. And Liz Malia, who is sitting to his right, is the House of Representatives Chairman of the Joint Committee, whose rep district includes Jamaica Plain, Roslindale, Roxbury, and Dorchester. Next to Liz is Ray Tomasi, who is the CEO of Gosnold on Cape Cod. Most everybody here knows Ray. Gosnold is the largest provider of mental health and addiction services on Cape Cod, with inpatient programs in Falmouth and Katamet, and outpatient counseling centers in Falmouth, Hyannis, Pocasset, Provincetown, Orleans, Mashpee, Brockton, and North Dartmouth. Next to Ray is Dr. Robert Friedman, who is a Sandwich resident and handles addiction cases at Gosnold on Cape Cod. Next to him is Sheriff James Cummings, who is joined by Dr. Stephen Dakota and registered nurse Jessica Gallagher, all of whom will be describing a pilot program at the Barnstable County Corrections Facility that will use an innovative treatment program to assist prisoners with their addiction recovery efforts upon release from the county lockup. And finally, but not as a presenter on the panel, is Lisa Murphy. And Lisa is, and all of the white shirts out here in the audience that say Parents Supporting Parents are members of the group in Mashpee. I spoke to this group a couple of months ago, and it was one of those evenings that really touched me because I was talking with parents, all of whom have children with addictions. That support group is so important, and I congratulate Lisa Murphy for leading that group. And I hope that other people in the room here will reach out to anybody who is in one of those shirts and talk about that support group. She will introduce the group to us at the end of the presentation. Now, as far as state legislators, other than the ones on the panel, we have with us, I'll start with Lance Lambros, who, to recognize Lance Lambros, who is the Cape Cod coordinator for Congressman Bill Keating. Where are you, Lance? Can you stand up there? You're back in the back, up in the second tier there. Bill Keating has co-sponsored a bill that's very important on the federal level that's going to be dealing with how manufacturers of opioid drugs actually tabletize this drug and how they can make it less useful for the people who are trying to use it in a non-medicinal way. So thank you for coming out tonight, and I believe there's some summaries that Lance brought that are outside that you can take with you on that particular bill. We also have from Senate President Therese Murray's office, Steve Marr here, and as Steve, you can make your way up here, I'm going to have him say a couple of words, and followed by Representative Sarah Peak, who is out on the end of the Cape, going from Provincetown all the way out towards Orleans and Harwich, I believe, and Brewster even too, right? So I would like to give a couple of minutes to each of those two representatives, or representatives of the representatives. Come right on up, Steve.
Hi, again, my name is Steve Marr. I just want to thank Randy for putting this together. This is really great, and having the panel here. I just wanted to address a few things. Randy did mention the bill that passed through the Senate. It's now in the House Ways and Means. It's a really important bill, and I think most people here will probably be able to agree with that. I think the Senate President, when she was interviewed about it, really said it best. She said, when drugs like these are responsible for more accidental deaths in Massachusetts than car accidents, we have a problem. And that's exactly one of the main reasons in pushing this bill forward. It really does kind of recognize the quiet epidemic that's going on in the Commonwealth. We actually, I think, from a study, in Massachusetts ranked was one of the highest in opiate abuse, and that's something obviously this bill looks to combat overall. A few of the things the bill does is really first, mainly is to identify early on addiction problems. And one of the simpler ways of doing that is basically to inform people about these issues and about basically addiction and how quickly it can happen with drugs like Vicodin and OxyContin. And basically just giving out pamphlets to people to make sure that they read them and understand the risks of taking these medications. I think one of the more local issues that we saw recently was the unfortunate public display with the former Red Sox coach Terry Francona, where he was on painkillers and he didn't realize that he had possibly formed a dependency on them, and he actually did have to see someone and talk about this. And that's something I think we really need to encourage, is people reaching out and realizing that yes, they may have a problem, and like anything, the earlier you catch it, the easier it is to treat. The other thing these bills do is really to try and capture abuse. People doing doctor shopping, going to any doctor to basically see who will give them the pills that they want. So the main way they did this was to create basically enrollment in the state's prescription monitoring program. And what that does is basically have all the doctors, they had to sign up for it. Those that prescribe a lot of drugs have to do it in the next 12 months. Doctors that see less patients over the next 2 to 3 years. And really what that'll do is be able to keep tabs on doctors who are prescribing these drugs, who are they going to, and also making sure that people that have a lot of prescriptions aren't going to a lot of different forums, aren't going to a lot of different pharmacies to get these drugs. So it's easier to keep track of and easier to see if abuse is happening. So that's a few of the things the bill does. I don't want to take up too much time because I know that we have a full forum here of people a lot more intelligent than I am. So I want to give them a chance to say as much as possible. But thank you for the time.
Thank you, Steve. And our state representative from the 4th Barnstable District, Sarah Peak.
I have to grow a little bit to reach this microphone. There we go. Hi, everybody, and welcome. And Randy, I want to thank you for putting this forum together. In Provincetown, we refer to Sandwich as the end of the Cape. But I guess when you're in Sandwich, you can call Provincetown the end of the Cape. But I'm here this evening. We're joined by Representative Demetrius Atsalis from Hyannis, who's here. Demetrius, why don't you stand up? There he is. And this is more than symbolic, but for a moment, let's dwell on the symbolism, because it's incredibly important as we're dealing with this issue of opioid abuse and addiction. We have the Upper Cape, the Middle Cape, the Mid-Cape area, and the Outer Cape all represented, because this is an issue that knows no town boundaries. It knows no boundaries across geographic lines, geopolitical lines, party lines, or socioeconomic lines. And thank you so much. I want to welcome my colleagues from the state legislature coming down from Quincy and Jamaica Plain tonight, respectively, the senator and the representative. We have a great Cape Cod turnout for you. I am here to listen and learn. So with that, I'm going to take my seat in the audience where I can soak in all of the information from this great panel of experts as you address this issue that, as I was thinking about it, it's sort of like if you take a stone and you throw it into a quiet pond and the rings start to circle out from that. Maybe the first ring that's affected is the family. And then we see our schools affected. Then we see the healthcare system burdened. Then we see law enforcement having to deal with this. And then, as Sheriff Cummings, I'm sure, will share with us, the number of people who are incarcerated as a result of what I'll call this scourge that we're all facing. And again, Randy, thank you for doing this evening. It's important to draw attention to it, but I particularly appreciate the positive approach in seeking solutions. Thank you.
On my smartphone, if you want to call it that, I did get a text saying that Demetrius was on his way. Thank you for being here. as well as Tim Madden. I don't know if he's in the theater yet, but Tim Madden is the state representative that represents Nantucket, Dukes County, and part of Falmouth as well. So thank you in advance for that. All right, we will get started with the opening comments from Will Luzier. Take it away, sir.
Good evening, and thank you all for coming this evening. And thanks also to the Sandwich High School. I know there's a lot of work that goes on behind the scenes when these events happen, and so thanks to everyone who helped put this together. Thanks to the Joint Committee on Mental Health and Substance Abuse for hosting this forum. I just want to say a little bit about the Interagency Council on Substance Abuse and Prevention, for which I'm the executive director. It's made up of the heads or their designees of 19 state agencies, 3 branches of the trial court, 4 legislative appointments, and several other appointments by the governor, as Randy said, chaired by Lieutenant Governor Tim Murray, and charged with fostering the standards for substance abuse treatment and prevention, along with the Bureau of Substance Abuse Services throughout the Commonwealth. And I need to say a little bit more about Randy Hunt. Randy Hunt is one of the most, if not the most, I will say one of the most active legislative members of the Interagency Council. You are very lucky to be represented by him at the State House. He asks all the right questions. He attends all of the meetings. He even makes a wisecrack once in a while, if you can believe that. I think of all the panelists, I'm the only one who didn't get a specific assignment. I was only asked to make some opening remarks. So I thought I would take a few minutes to tell you about some of the work that the Interagency Council has been doing recently. In mid-January, there was a 4th recovery high school that was opened in Brockton. There were previously 3, one in Springfield, one in Boston, and one in Beverly. Now the 4th one in Brockton is administered by the North River Collaborative. And recovery high schools are places where kids can go when they get out of treatment, and if they went back to their own high schools, they would start running with the same crowd and start using again. So these are schools where there's a supportive recovery environment, along with an educational component. They're full-blown high schools, and there've been over 500 high school students over the past 5 years that have had the opportunity to work on their recovery at these schools. We've recently been working with the Executive Office of Public Safety on a Second Chance Act grant. The Second Chance Act is a some congressional legislation that allows folks to give services to people who are coming out of our prisons and houses of corrections. So they're called reentry services. So we're working with the Department of Corrections, probation, parole. We'll be working with the sheriffs, folks in housing and homelessness and domestic violence. There's a big stakeholder meeting that's happening on May 14th through the 16th, and we're in the process of planning that. There are, on April 24th, there's a kickoff for our town hall forums. SAMHSA sponsors these forums every 2 years. There will be 60 cities and towns across Massachusetts who will have town hall forums in the coming months. And these are town hall forums to talk about prevention of underage drinking. And SAMHSA always sponsors these for underage drinking. This year, we are going to couple that with prescription drug abuse prevention. So as I said, there'll be 60 cities and towns across the Commonwealth who will have these fora. And one of the reasons why we've coupled underage drinking and prescription drug abuse is because there are, for someone who is alcohol dependent, they are 18 times more likely to abuse prescription drugs. And so there's a real connection between alcohol dependence and prescription drug abuse. On April 28th, and you should all put this on your calendars, there's the 4th DEA Prescription Drug Take-Back Day. And these drug take-back days are sponsored by local police organizations, usually at police stations. There have been 3 DEA drug take-back days since they began, and just in Massachusetts, there were 16 2/3 tons of prescription drugs that were returned. And this is an opportunity for people to clear out their medicine cabinets, to get rid of all the dangerous drugs that might be there, and have them safely disposed of. And we're also working, this Thursday, I think, is the due date for a drug court enhancement grant that we're working on with the trial court, probation, the Bureau of Substance Use Services, of course, and advocates, and it will provide training and technical assistance for around medication-assisted treatment. There'll be promulgation of uniform screening tools, and this will help make the drug court experience in Massachusetts uniform from court to court. So, lastly, I have some good news and some bad news. The good news is that, as Randy has said, my friend Michael Botticelli is going to Washington as the Deputy Director of the ONDCP. That's the White House Office of National Drug Control Policy. So that's the good news. The bad news is that Massachusetts is losing his leadership, his energy, his acumen on all of these issues. But as Michael will tell you, the work goes on, and I never pass up the opportunity to talk about the great staff that Michael has assembled in the Bureau of Substance Abuse Services. They're among the most committed people and dedicated people that I've ever had the opportunity to work with. And so those folks none of them are going to Washington with Michael, fortunately. So they're all still going to be working, and there's allegedly going to be a national search for a new director. Whoever takes that position has very big shoes to fill, and so I'd like to turn the microphone over to Michael at this time. Thanks.
Part of my regret about leaving Massachusetts is that I have the great pleasure of working with all of these people up here, and if we've been able to do anything, it's because it's been a partnership. And if anyone is interested in a house in suburban Malden, it's not on the market yet, and we can cut out the real estate agent and split the difference. But thank you for being here, and I really want to thank Representative Hunt, particularly for framing this as looking at solutions, because what I see is that when communities, when state leadership pulls together, when communities pull together, when parents pull together, that's when we get solutions. It's really when we pretend that we don't have a problem is when we stay stuck in the problem. So I really want to thank you for doing that, because we do know what works, and there is hope, and that we do see kind of effective prevention programs, effective treatment programs, effective strategies and policies and laws that can really work to do this. And I want to especially thank Will. I get the pleasure of working with him and the Lieutenant Governor and the state agency, and there's really no more supportive environment. And I also want to echo something that he said, and I know that we're particularly here to talk about prescription drug use issues and the opiate issues that we have here. But if we really, really, really want to prevent substance use issues, we've got to start young. And we've got to start focusing on our youth before they start doing anything. And that's really the issue here. And, there are some particular issues relative to prescription drug use that we have to talk about, but we often don't talk about alcohol in those conversations. And I think as Will said, that we know that kids who are dependent on alcohol are much more likely to misuse prescription pain medication. We also know that kids who drink at an early age are more likely to use illegal drugs. And so part of what we have to talk about really is what is our thinking and what are our community norms around alcohol? And what are our policies and programs? Fortunately, one of the most effective prevention strategies that we have around alcohol is raising the price just a few cents. And here in Massachusetts, we actually we were one of only very few states that that categorized alcohol as a necessity, right, and therefore exempt from the sales tax. And, so it's no surprise to me, quite honestly, that we have some of the highest underage drinking rates in the country when we have some of the lowest taxes and some of the lowest prices on alcohol. So I want you to remember that. So as you think about solutions, yes, we have to do some specific things relative to prescription drugs and prescription pain medication, but we also, from a prevention standpoint, really have to look at early onset, and particularly as it relates to alcohol. So, let me read you this quote. This was from a parent of someone who was in, this is from a mom who was in one of our recovery high schools. So when my daughter was about 13 years old, she started to smoke pot and drink alcohol. She didn't take care of herself. She was tired, cranky, and very emotional. She used OxyContin and eventually became addicted to heroin. And I think you all know those stories. We have our parent support group here, and I think unfortunately that story gets replicated many, many, many times. And so, again, while we need some specific strategies around prescription pain medication, if we're really talking about prevention, we've got to start early. One of the things that we do see is there are some particular things about prescription pain medication that because a doctor prescribes them, that people generally see them as safe and effective, that they don't cause harm. One of the things that we know, doctor shopping contributes to the problem, but we also know that a significant amount of diverted pain medication is coming right from people's medicine cabinets. And I often say this is an epidemic of the medicine cabinet. We've been taught as a society, if you get a pain medication by a doctor, it's valuable. And if you only take a little bit, you stick the rest in the medicine cabinet and you'll wait. You wait till you need it again, or you wait till someone else needs it again. And that's a large part of where prescription pain medications are getting diverted from. So, one of the things that we say is really effective is disposing of your medications and participating in DEA programs, but also encouraging friends, relatives to do that. So, kids are very savvy at knowing that, many of our elders are on prescription pain medication. And so if your kids start paying, more and more visits to grandma's house, that there might be an issue here. So part of it is tell not just you, but tell your friends and family in terms of the disposals. We've seen a dramatic increase in the number of prescription pain medications, both here in Massachusetts and nationally. And one of the things that I think we have to be conscious of is the fact that, pain medication really has a value for many, many people. And so, we always have to remember that what we're trying to do here is not limit pain medication for people who really need it. What we're trying to do is make sure that we're getting, and we're having physicians and healthcare system that prescribe it appropriately, and that they're prescribing it to people who don't necessarily have a problem with prescription pain medication. And I've told this anecdote many times. I've been in recovery for a long, long time. And I had my dentist, I went to my dentist and he knew I was in recovery. He knew I was a state guy for substance abuse, and I had a dental procedure, and I left. And he said, "Would you like a prescription for Percocet?" And I said, "Doc, you don't get it. I'm not the guy you should be giving a prescription for Percocets to. Why don't you take extra strength Tylenol? And if your pain is still, first of all, I shouldn't be getting Percocet for a routine dental visit, but, and we're going to talk, Cedric Keenan's going to deal with that. But honestly, and I don't say this to blame the healthcare profession, they are not routinely trained in substance use issues. It's one of the few diseases where they don't get relative training about. So we talked about that. We also talked about just doctor shopping, and I'm also very conscious of lots of anecdotal stories on the Cape about prescription pain medication coming from other states. So, I think all of us have heard horror stories about Florida, and I think it's estimated that 50% of the prescription pain medication prescriptions in the United States are from Broward County in Florida. And that we know that there's an express up the East Coast in terms of some of those pain medications. So part of it is we also have to look at how we implement programs in other states, because we know that can be a pipeline for some of the issues here. As Representative had talked about, one of the issues that we've seen has been a dramatic increase in opiate-related overdoses here in Massachusetts, and over the past 10 years, that has really skyrocketed to the point where the latest data that we have is about 600 people in Massachusetts died of a fatal opioid-related overdoses, and the way that we often talk about that is 2 people a day. 2 people a day are dying dying in Massachusetts as a result of a fatal overdose. And so clearly this is a public health issue, a significant public health issue that we have to pay attention to. One of the things that Representative also talked about is now we see opiate-related overdoses exceeding motor vehicle fatalities, not just in Massachusetts, but at last count, I think there were 19 states where opiate-related overdoses deaths exceeded motor vehicle fatalities, and that so it's not just a Cape issue, it's not just a Massachusetts issue, but it's really a national issue that we've got to focus on. One of the things I talked about is kind of not acknowledging that there's an issue, and there's been a number of studies, and I think this is particularly important for parents that often show that parents often underestimate what their kids do and what their kids use and what they drink. And so, part of what we can't do is live in denial in the fact that, just because our kids are good and maybe are doing well in school and are athletes doesn't necessarily mean that they don't have a problem. So part of what, I think we all have to do is clearly pay attention, but also talk about and talk to our kids often in terms of what those issues are. So I just want to talk a little bit in terms of some of the things that, what are, and some other panelists are going to talk about some of the solutions, but one of the things that, I really want to point out is that there's no silver bullet here. There's not just one thing that people can do. There's not just, we try not to look at from a blame perspective, but there's not one thing that's at fault, and there's not one thing that's going to be the solution. That we need to really look at a whole host of issues that we can talk about. And from a prevention perspective, parents play a key role. So the example that you set, particularly for your middle school kids, can really set the example for what happens. So how you use alcohol can really have a direct effect in terms of what your kids understand is the appropriate use. Clearly as kids get older, talking to them, setting clear limits, following through on that limit setting is really, really important. We have a number of booklets. There's some out front, but you can also get them from our website. And it just gives parents some helpful tips about, is your teen using? So how do you identify the signs and symptoms of whether your kid's using? How do you talk to your kids? What are helpful things to say? What are helpful ways to frame the conversation? So those are, they're all free of charge. They come from your taxpayer money. So I want you to make sure that you take a look at those. As Will talked about, we're hosting helping to host 60 town hall meetings across the state, focusing not just on underage drinking, but prescription drug use, so that we replicate forums like this all across the Commonwealth. One of the things that's really important, again, we talked about physician training. And so in previous legislation, there was actually laws that were passed that required physicians, as part of their continuing medical education, to learn about safe opioid prescribing practices. And we have also been participating with the Board of Registration in Medicine that license physicians in prescribing seminars. And actually this Saturday, we're hosting our 7th prescribing seminar for physicians because, again, I think physicians are often pressured about treating pain appropriately, but are not necessarily really trained in understanding addiction. So we really have to make sure that we're giving them adequate information and training to look at that. We were also fortunate to get some additional federal money, and we focused and gave out 15 community grants across the Commonwealth to really focus on those areas that were hardest impacted by opiate overdoses. And so we're happy that we have additional funding to continue those grants and actually to expand those, as well as we'll be coming out next year with our next round of underage drinking grants. And I understand that Sandwich is going to be applying for a drug-free community grant. So I think that's really an important step in terms of the work that you can do. The state also has been enhancing our prescription monitoring program. And what that means is that it will allow physicians in a real-time way to understand if someone is doctor shopping, if someone is going to more than one doctor, not just physicians, but pharmacists as well. And Senator Keenan is going to talk about some proposed legislation that will enhance those, but it will really give healthcare providers access to more real-time information to make sure that they're not continuing to give very, very potent pain medication to people who don't need it. Part of my concern is I want to make sure that those folks don't just get cut off from the medication and get sent on their way, but that we really look at that as an intervention opportunity to get them into treatment. So I think that that's, particularly important. One of the things that I think, again, speaks to this issue is how we do a better job at identifying substance use problems before they reach really before they have major consequence. And so one of the things that we've been working on is implementing what we're calling screening and intervention. So we're actually working with school nurses, school-based health centers. We've been working with our emergency departments and other healthcare providers so that when you have a medical visit, someone's asking you about your substance use history. So let's not wait till people progress till they developed an addiction, but let's intervene early, right? So if you have a heart condition, someone doesn't wait until you have a heart attack before they decide that you get treatment. And unfortunately, with substance use, we've created a system where we wait till people develop an addiction before we decide that they're ready for treatment. And what we're trying to do is really say, let's look at identifying people early when they're starting to develop a problem, when we know we can do a better job at intervention. So we're really focusing on that. We're working on the Caban and other places. I think many of you, and particularly our parents, are familiar with our efforts to expand Narcan. And Narcan is basically an antidote for an overdose. It's a safe, non-toxic medication. And so we've been training parents, first responders, and users themselves to administer Narcan in the event of an overdose. We know that people generally don't use by themselves, and we know that they don't overdose generally by themselves, and that other people are coming upon them. And so over the past 3 years, we've been expanding. We're one of the few states that have trained a wide variety of people to administer Narcan. And, as of this date, we have, I think, over 11,000 people enrolled in our Narcan program and have reversed over 1,300 overdoses in Massachusetts. And so, again, we don't want to see people get to an overdose state, but we also want to make sure that we keep them alive so that we can get them in treatment or get them back into treatment. And if you listen to stories of parents, it's really compelling, when they're kind of walking in and saving their own child's life. I think there's nothing more dramatic than that. We're also working with the legislature to pass Good Samaritan legislation. And Good Samaritan, one of the reasons that we know people can often die of an overdose is that they're afraid to call the police, because they're using illegal substance. And what Good Samaritan does, it provides people limited immunity to call 911 in the event of an overdose. And that we've been working with some police departments in terms of Narcan, but one of the things that we want to do, and some other states have already implemented this, is to give people some limited immunity if they're calling 911. One of the programs, and I want to thank my colleagues at the legislature. A number of years ago, we got an additional legislative appropriation. We were hearing from many parents whose young kids that they knew had a problem and they didn't know where to turn. They didn't know what was helpful or what was unhelpful about helping their kids. And so we got additional money to expand what we call family intervention programs. And Gosnell, who is doing that, actually has one of those grants. And I think some of the parents involved in the support group have used that. And so we really are excited about having some resources for parents and some counseling for parents whose kids may have a problem. One of the things that we know, one of the most effective things that we know is kind of getting and keeping people into treatment is really one of the most effective things that we can do. And again, we've been really fortunate here in Massachusetts that even despite some really difficult economic circumstances, both the Patrick administration and the legislature have found a way to preserve our funding. And so I'm not supposed to tell you to advocate for funding, but you have an opportunity here with your state legislature who are now going through the budget process to make sure that we preserve funding. So I think I've gone too far on that. But I'm leaving anyway, so what are they going to do, fire me? But one of the things that, again, I think that we have here in Massachusetts is a pretty significant treatment system. So we do have treatment resources available for folks, both for adolescents. In addition to Recovery Highs, we have youth detox programs, youth residential programs, and Recovery High Schools, and we have a full continuum of care for adults in our system. And the vast majority of our people generally have health insurance, which is really great, and that's many of them have insurance. You know, one of the issues that we see that we hear often from parents, it's not if you don't have insurance or even if you have Medicaid, but often commercial insurance can really be an issue in terms of getting kids into treatment. So not necessarily state funding, but commercial insurance. So, you know, we now have parity laws both here in Massachusetts and nationally, and it's going to be interesting to see how we make sure that commercial insurers particularly are meeting the requirements that they can't treat substance use different than they do other diseases. So, you know, we continually hear that, and it's an issue that I think we need to spend more time on. So I'll end there. I probably went over my 15 minutes, but thank you.
You did. That's okay. Thank you. Michael, I really thank you for your expertise and your passion in this area, and we are going to miss you, but come back often. And now we're going to talk about the bill, the Senate 2125 bill, and Senator Keenan and Representative Malia will give that presentation so that people can understand, and I hope that we'll be able to pass this very soon. And maybe you'll be able to give us some ideas to how likely it is for the House to be able to vote on this within the next few months, too. Thank you.
Thank you, Randy, and thank you to the gentlemen who, Will and Michael, who have kind of outlined the problem that we confront here in the Commonwealth. And as was said earlier, it's appropriate that tonight's forum focuses on solutions. As a parent of an 18-year-old, a 16-and-a-half-year-old, and an 11-year-old, having been appointed the co-chair of the Mental Health and Substance Abuse Committee and being exposed to this, it scares the living daylights out of me. It is an epidemic that has been described as silent, but nonetheless it is a very, very substantial epidemic. And as recently after being appointed co-chair of the committee in my community and the communities that I represent, people came forward to share their stories about family members, about friends, about relatives, and it just seemed to come from everywhere. And while living in the city of Quincy, I wasn't immune to it, it was a bit of an eye-opener as to the extent of the problem. So in that context, we looked at ways, myself and the co-chair, Liz Malia, of how do we go about having an impact on this epidemic, trying to stem the epidemic, knowing that our resources are somewhat limited. We know that recovery programs are very expensive. We try to fund those as best we can because I think we all agree you can't put a price tag on somebody who's in need of help. So we try to do the very best that we can in that context. So what do you do with limited resources? How can you address the problem? I was at a forum in the city of Quincy, and somebody brought up in the discussion the drug take-back days that Will had talked about, where 16 tons had been returned. And the individual said, maybe we should start thinking differently. Maybe we should start thinking, instead of 2 drug take-back days a year, we should look at 4 or 6 or 8. And my thought on hearing that was, there's an alarming number of pills that are out there, and if we believe there is the need for 4 times as many drug take-back days, then that was a clear indication to me that there is at least 4 times too many prescription drugs out there not being used properly and capable of being diverted and misused. So that kind of was the foundation on, or the idea behind attacking this from a prevention perspective. We wanted to increase the public awareness of the dangers of prescription drugs. We wanted to reduce the supply that was there and available for diversion. We wanted to make it tougher on addicts and dealers who were using the system to doctor shop to get their pills through fraud. And we wanted to increase access to treatment programs. So we set about putting together legislation. We set about meeting with just about every group, every individual that had a concern or was involved or affected by this. And we did it over the course of several months. And we came up with a plan that became legislation. And just to go through it briefly, it was mentioned earlier that we have a prescription monitoring program here in the Commonwealth. What that means is when you go to a pharmacy and have a prescription filled, key information about that prescription is entered into this prescription monitoring program. It's there, it has been there. The problem has been it not utilized. There's some general information that comes out of there that's very helpful. It allows the Bureau of Substance Abuse Services to target resources and things of that nature. Yet we found that physicians weren't enrolling in the program. 2 years ago, there was legislation passed, and Representative Molly was very active in that, and it required physicians to receive the education that Mr. Botticelli had just mentioned. And to this point, I think about 3,500, I may be wrong on the number, have gone through this educational program. And yet only 1,700 enrolled in the prescription monitoring plan. And of those 1,700, very few were utilizing it. There was the ability for a doctor to pull up a patient's record of prescriptions, and yet it hasn't been occurring. So the legislation would make enrollment in the prescription monitoring plan mandatory. It would target the 30 physicians, and I don't want to use target because that sometimes has a negative connotation to it, but nonetheless would focus on getting the 30% of the physicians who write 90% of the prescriptions into the program. And that's not to say that those physicians are doing anything wrong. They're writing a lot of prescriptions because there's a lot of pain out there. There's pain in the context of cancer, there's pain in the context of orthopedics, there's legitimate pain that needs to be treated. And there is a group of physicians who actively treat that pain. But we wanted to get those 30% who write 90% of the prescriptions enrolled in the program as soon as possible. So the legislation looks at getting them enrolled in the course of a year, and it looks at getting all physicians who write prescriptions into the program over a course of 3 years. Now, once they're in the program, as some are, it's not being used, so we wanted to mandate the use of the program. And we wanted to do it in a way that struck the balance between what doctors have to do, the time limits that doctors face, the time constraints, and yet balancing that with the epidemic that's out there. So the legislation would require a physician, when that physician is prescribing a prescription painkiller for the first time, to run a prescription monitoring screen on the patient. The physician would log in, put the patient's name into the system, and would get from the prescription monitoring program a report as to what that person's prescription painkiller history is. Again, this information is available already. This would require doctors on the first time that they're writing a painkiller medication to check that. It allows the doctor to see if there is a history of dependency, addiction, abuse, doctor shopping, whatever it may be. It also allows the doctor to make an assessment if somebody's been prescribed a couple prescriptions over the course of a couple of months and maybe has used them faster than expected, to have a conversation with the patient. Where are the pills? Well, I doubled up. Why did you double up? Because I'm in pain. Greater pain than I thought I would be. It allows the physician, or it will allow the physician then to have a discussion with that patient about pain. And if the doctor is convinced that there's something other than legitimate use of the medication going on, or that somebody is progressing down the path of dependency and addiction, it will allow the physician to have a discussion with the patient about that. Maybe wean them off, or if need be, refer them to a treatment program. So the physician will be required to run a screen the first time that they're writing a prescription. I had an individual approach me who had heard about the legislation, was concerned about its impact. The person said, I had bone cancer. I would not have gotten through that with the pain unless I had my OxyContin. And he said, you're going to have an impact on that. You're going to take away the ability of doctors to handle pain in those situations. And my response was that when he was diagnosed and he went to his oncologist, and the first time that oncologist decides to write a painkiller medication, a prescription for a painkiller, he or she would have had to check the prescription monitoring program. And from that point on, it would be up to the physician and the patient to determine what was appropriate. That it was that just one-time check that's required under this legislation. And so it would not have an impact in cases such as that. The other thing that we're looking to do, have physicians do with this legislation, is to develop best practices. We learned in the course of researching this bill that emergency room physicians treat pain differently than oncologists, who treat pain differently than orthopedics, who treat pain differently than podiatrists, who treat pain differently than dentists. And so this legislation will require physicians to come together in a group and to develop best practices. Some of the early discussion among physicians is that perhaps in the context of an emergency room physician would be limited to writing a painkiller prescription that for 3 days. Maybe it'll be 5 days. Maybe they'll decide to do it on the number of milligrams that's that they can prescribe over the course of a period of time. We don't know exactly what they will do, but they will meet, they will develop best practices, And those best practices will then become regulation. And it's our expectation that those best practices will shape how physicians handle pain, and particularly how they prescribe painkillers over the course of the coming years. The other component of the legislation is the education component. When somebody goes to a drugstore to fill a prescription, they will get a very stark, clearly worded piece of literature that tells them the dangers of prescription painkillers, the signs of dependency or addiction, what they can do if they see those signs, where they can go. It will also tell them what they can do to properly dispose of the medication. And that education, we think, is important because, as Mr. Botticelli and Mr. Lucia said, people don't seem to appreciate how dangerous these drugs are. They're approved, they're prescribed, you have to get them over the counter, by way of prescription. They're regulated, so really, they're not that dangerous. You're not buying them on the streets at the outset. They're not an illicit drug. They're doctor prescribed, so they can't be that dangerous. We have to attack that attitude and make people aware just how dangerous these drugs are. The other thing that we observed in the course of drafting this legislation is that although there had been legislation in the past requiring the state to move to its secure prescription pads, we didn't think that was happening fast enough. We do realize that within the next couple of years there will be a requirement for electronic prescriptions, but in the interim, this legislation will call for the use of secure prescription pads. They're already used in cases of mass health. This would broaden that to painkillers across the board. And just as by way of a story or anecdote, recently there were 64 individuals on the South Shore, I think it was 64, who were involved in a legal prescription pad case. They were writing false prescriptions and passing those prescriptions and getting those prescriptions filled. And so this would address that. The Good Samaritan part of the legislation was discussed earlier. We also have in the legislation a parental notification piece, where if a child under the age of 18 is taken to an emergency room with an overdose, the parent will be notified and the parent will be given information upon discharge as to resources that may be available, that are available for the child for recovery, whatever the case may be. There's also a provision in the legislation for professional training of court personnel and legal counsel, and there's a piece in the legislation about medication-assisted treatment programs, which will be discussed later by the sheriff. So the bill attempts to be comprehensive, looks to be cost-effective, but more than that, hopefully will help stem the tide of this epidemic. The legislation has passed the Senate. It's in the House Ways and Means. And I'm new at this, I've only been in the legislature for a year, but you learn pretty quickly that on just about every piece of legislature there is pushback. There's pushback from people who have different concerns about the legislation. And with this piece of legislation, we tried, as I said earlier, to meet with as many people, to get as much information as we could. The pushback has been relatively minimal. Some doctors have some concerns, the pharmaceutical companies have some concerns, the pharmacies have some concerns, but the concerns have not been so great to really have a substantial impact on the likelihood of this legislation passing. So we're optimistic, we're hopeful that it will make a difference, and we are going to keep working on things as time goes on in an effort to come up with better ways to address this epidemic, and whether it be further efforts relative to prevention or better efforts and more efforts, I should say, on the recovery side. We'll do whatever we can. Thank you.
Representative Malia, do you have some comments to add?
I will try to be brief, but I first want to thank you, Representative, for inviting us and helping to put this together and motivating members of the legislature, all of us on the committee, to begin finding out what we need to do to improve the education and outreach part of the mission of our committee. And Randy mentioned that at the outset that he was a minority member of the committee, and I just want to reiterate the fact that he is in no way a minor member or player on the Mental Health and Substance Abuse Committee, and I'm very grateful for that personally, and I think all of us in the state are grateful. We've had some extraordinarily talented and motivated legislators on the Mental Health and Substance Abuse Committee this past session. And one of the reasons I'm so grateful to be able to participate in a forum like this and to serve as the chair is because we've reached a point in time where I think the general awareness of what a serious health problem we're facing in substance abuse in general, but also specifically in prescription drug abuse. We are reminded almost every day. Last week, I went to a funeral for a family friend. As a gentleman who was 44 years old, had 3 kids, and his 11-year-old daughter found him in the morning, deceased. No obvious health risk of any sort ahead of time, and we don't know exactly what the cause was, but we know that there were some issues there in terms of prescription drug use. And again, it's not that often that someone would die at the age of 44. The pain that's going to create for that family is just unbelievable. And I know that some of you here can speak to that much more effectively than I can. But the other issue is that not only is there an issue around the amount of pain and suffering and human suffering and loss and waste of human talent and potential, it's also beginning to become a point where it's costing us an incredible amount as a state, as a country, to treat and respond to and try to intervene in the problems that have been developed by this epidemic. One of the reasons there is a mental health and substance abuse committee at the State House is because a few years ago, when some of the legislative leaders and governmental leaders were looking at the rising cost of health care, one of the things they looked at was how much the cost of treating the effects of substance use and dealing with mental health issues had become so much greater and were really affecting this incredible spiral of healthcare costs. So we've been able to start focusing in on specific areas like mental health and substance abuse. And one of the things that we've come up with, is clearly we feel like we've opened the door. I think a lot of us would agree with that. We've opened the door and found a much greater flood coming in than we had thought. It might have seemed like a trickle, and occasionally some of us might hear of one or two, a famous person who has a drug problem, or we might find out about a family member or somebody in our community who has had a problem. But when you look back at the numbers and you see how much we've gained in knowledge about pain relief, and we understand that as appropriate as that is and as necessary as that is, the technology has taken off and gotten way ahead of us. And we haven't been able to find ways to properly oversee and look at the safety issues that are involved here. And among other reasons, one of the greatest reasons we have to begin addressing this problem is because we can't afford the cost in medical care, the cost in human suffering, the cost in emergency care. When you realize that more people die of overdoses than die in car accidents, you begin to start realizing that there's much more that we have to look at here than we have before. I started in the legislature in 1998, and at that point in time, when you look back at the statistics, there were very few problems with prescription drugs. We had problems with about the same usage, unintentional overdose deaths with heroin that have stayed relatively stable during those years. But the growth in the instance of overdose deaths with opiates has just really started to skyrocket. And I think, again, I feel as if it's a responsibility for many of us in a legislature to begin addressing this. We have a lot to learn, but we've also, we're very highly motivated, I think, and we're lucky to have some of the folks with us today that can begin to address this. And I know you'll hear next from some of the folks who are working in addiction treatment, who are local resources and have a lot to teach us. So I'm going to turn it over to Randy and to Ray Tomasi.
Thank you, Madam Chairman. I appreciate the comments. Ray Tomasi and Jim Cummings and I did the radio tour just a few days ago, and these programs got aired on WXTK and WQRC over the weekend. And one of the things that Ray said to me that I felt really good about was that he's positive. He said, we can beat this. We need to put the resources in the right places, and we need to be smart about how we deal with these issues. And so I'd like for Ray Tomasi, who's CEO of Gosnold on Cape Cod, and Rob Friedman, who's Dr. Rob Friedman, there to talk about the things that they are doing at Gosnold to help us move the ball down the field on trying to get our hands around this big problem.
Is it on? Yeah. Is it on? Yes, it's on. Thank you, Representative. I think probably the first thing I want to say is that I think it's not insignificant that that this forum starts out with the word solutions. And I know that when we were doing the radio programs, there was some emphasis on those, on that as the key issue. I think that we've recognized for a long time that there are serious problems, that there is a fragmented system, sometimes a fragmented system of care, and we've focused on, and we need to, on a lot of the tragedies that occur, because the tragedies that occur are the things that motivate us to overcome. But I do think that we are on the precipice of some very significant things that are going to make a difference in the future. I think part of what I'd like to say, I want to give a little bit of data about things that I looked at today that are pretty startling, I think, just relative to our own treatment system here on the Cape. Maybe I ought to do that first. Statewide, and these are admissions to acute treatment services, which are detoxes. In the state, about 20% of the patients admitted to detoxes are under the age of 24. At Gosnold, 30% of the patients admitted to detox, which is really like the emergency room for addiction. 30% of the patients are under the age of 24. It's the highest percentage in the state, actually almost parallel with us is High Point, which is also southeastern Mass. Now, patients come to Gosnold from all over the Cape, from throughout southeastern Massachusetts, and sometimes beyond. The primary drug identified by patients as their primary drug of addiction, statewide, heroin 57%, prescription drugs or other opiates 10%, alcohol 28%. The Gosnold numbers are heroin 21% versus 57% statewide, prescription drugs or other opiates 29% versus 10% statewide, alcohol 45% versus 28% statewide. I think Michael's point about alcohol is significant, and because the reality is in this country we have about 22 or 24 million people who are identified as dependent on substances. 18 million of those people are primarily dependent on alcohol. So I think that as we make every effort to address the prescription opiate issue, that we can't lose sight of the larger picture about addiction, and addiction to alcohol remains the biggest problem in this country. The other interesting thing, so I looked at first time in treatment. Statewide, 12% of the patients admitted to detoxes, this is a very recent data over the last 6 months, 12% of those patients were in treatment for the first time. I was encouraged to see that at Gosnell, 26% of the patients who we're seeing are in treatment for the first time. Now, it's not good that patients are coming to a detox. On the other hand, the fact that people are coming to treatment a little bit earlier is an encouraging sign. And the last, and these numbers really correlate with all of I looked at our Miller House men's residential program, our Emerson House women's program, and these numbers correlate with them. The other thing which I looked at and which we've spent a lot of time working on at Gosnell is access to care. Statewide, to get into a detox, the average wait is 2.04 days. When a person's in crisis, that's way too long. At Gosnell, we're better than that, 1.3 days. At the same time, we're getting 800 to 1,000 calls a week, and when people make those calls, generally they're making them in moments of desperation, and what we're trying to do is respond to all of those calls the best way that we can. So the data certainly reinforces the perception that many have down here that other opiates or in prescription drugs are clearly have risen to a level that's unprecedented and certainly on the Cape and certainly in our state. It's about a 10-year phenomenon. It roughly corresponds with the issuance of OxyContin back in the late 90s, and it has essentially replaced any other sort of the other drugs that were in ascendancy back earlier were things like cocaine that have really receded into the background. So that's some of the data stuff. Relative to one of the things that we're trying to do sort of on a global level is change the conversation and change the language about addiction. And I think that, as Michael alluded to the fact that we have created a system that responds to individuals when they reach a point in their illness when they need to go to the hospital, essentially. And over the longer term, that is really not that doesn't have the greatest likelihood of creating good outcomes for most people. You don't wait until a person is late stage in any illness before you initiate treatment. And one of the reasons why that happens is because of the stigma of addiction. The stigma of addiction that exists in society, that exists in our healthcare system, that exists in our reimbursement system, that make it very, very difficult for folks to receive care at a time when they have the greatest likelihood of affecting a full remission. And I use that word purposely because it's part of the way we're trying to change the language about addiction. This is a chronic illness. People have it for their life. Once you have this diagnosis, you have it. And what we're trying to do in our system of care at Gosnell is to create a system that helps a patient manage their illness over the course of their lifetime. This is not a condition that you go into an emergency room, i.e. detox, or you go into a rehab for 2 months or 3 months or 1 month, and you come out and you're all better and you never have to worry about it again. And so our system of care is very sort of created in these sort of little silos. And there is this perception in our society that if you go to one of these silos, when you come out, it's all over. And if you have a setback, I don't like the word relapse. I try not to use it, but we use it in this business. But essentially, a relapse is a return to acute use. It's a recurrence of acuity in an illness. And when that happens, we want to try to get patients back to treatment to do what? To do the same thing that they do with other chronic conditions. Help the patient get restabilized, modify their plan of care, and get them back into remission. Because outcome, people say, well, what's your success rate? And I said, gee, I'm sorry you asked me that, because now you got to put up with a 20-minute conversation about about what that really means. But what are we trying to do when we treat addicted patients? We're trying to help them get and stay in remission. We're trying to extend those periods of remission. We're trying to shorten periods of acuity, and we're trying to improve functioning during the periods of remission. There's hardly any, I doubt that there's any chronic condition that a patient has where there isn't a periodic return to a crisis, if you will. Hypertensive patients very rarely live their entire lives without ever having a spike in blood pressure. Diabetes patients very rarely live their entire lives without having elevated blood sugar that requires that they go back to the hospital. And when they go back to the hospital, what happens? Everybody tries their best to figure out how to help them. But what happens when an addicted patient goes back to the hospital? That patient is characterized in a way that isolates them, that shames them, that stigmatizes them, and really discourages them. Who wants to go back to treatment when the likelihood is that you're going to be categorized that way? And at the same time, the treatment setting is somehow blamed for not making that patient miraculously better. So we're trying to help people think about this disease in a different way. And neuroscience is teaching us a lot of things about addiction. It's teaching a lot of things about how the brain reacts and responds to these drugs, very specific areas of the brain. It's very, very revealing, and it's very, very exciting because that neuroscience is going to lead to advances in care. Now, one of the things that we're trying to do, because we recognize at Gosnold that most people do pretty well in treatment. When they're in a confined setting, people in rehab do very well. But what happens when the person goes back home? What happens when the person is beginning to assume some of their own self-management for maintaining their remission? That's where they need a lot of the help. And so we don't have a great system for seeing that helping the patient during those periods, it's just not very good. We're doing some interesting things. We're using, as a matter of fact, one of our counselors is here tonight who's involved in this project that we're doing with the University of Wisconsin. It's a research project to see how smartphone technology can help us maintain communication with patients and give them opportunities to use apps, recovery apps on a smartphone that in the last case scenario, there's a little panic button on that app that they can hit. And when they hit that panic button, their counselor gets a notification. Our counselor, Christoph, is here. He carries one of these phones. And that little panic button will light up on his phone, and he can call that patient and say, how can I help you? So that we can help prevent and limit those high-risk situations where patients become very vulnerable. Recovery from addiction requires a long process, and it takes time, it takes energy, and it takes an incredible commitment of resources, of both capital resources and personal resources. So we're using a lot of best practices in our program, but ultimately we need to be seeing patients at an earlier point. And I thank Michael for pointing that out. If you think about addiction treatment in a pyramid, we're seeing probably 2 to 4% of the patients who are, let's call them later staged and identified and diagnosed. It's the people that are under that peak that we need to be thinking about. The people who have not gotten to the place, whose condition has not progressed, where are we going to find them? We're going to find them in primary care settings. We're going to find them in the mainstream of medicine. And that's an area also that we're working very diligently about. We're linking with primary care docs. We actually have a counselor in a primary care office working as part of the primary care medical team. We have a very innovative program that we're doing with Falmouth Hospital. We've done it for about a year now, where we're assisting and working with them to identify folks in the hospital who are admitted for other conditions, but whose underlying condition really is addiction. We've done consultations with the hospital in the last 15 months on 185 patients just in Falmouth Hospital to be able to help them manage those patients. And we're working very closely with the community health centers to link to them and become part of a primary care team that helps people not only with their physical and their history and physical, but also to do better screening, to catch people earlier. That's really where we need to be. And so, you know, the allocation of resources in addiction care, and I'm not going to turn this over, otherwise I never stop. Hey, you know, I get pretty passionate about this stuff. You know, in 2005 and 2009, the Columbia University, the addiction organization down there did some studies, and they said that they looked at all the states. In Massachusetts, they determined that for every dollar spent on substance abuse, there was a penny spent for prevention, a penny spent for treatment, and 98 cents spent to deal with the consequences of addiction, whether it was mental health care, child care, criminal justice costs, health care costs, education costs. The allocation of resources to treat any public health problem that had the impact on our society that addiction has, where it's under-recognized, misunderstood, underfunded, and treatment is underappreciated. If it was any other condition, you'd have a groundswell of opinion about that. So we need to keep telling the story of two things. Number one, this is a chronic condition. And number two, there are ways to treat it. Treatment works, and we see it day in and day out. And one of the things that we're doing also, which we're very happy, I'm very happy that Rob Friedman has joined us over the last 6 months, and is because we're doing some of these medication-assisted treatments. Medications have been developed that can help blunt some of the craving that's very critical in early recovery. We're using one of those particularly, which we think has great promise. It's called Vivitrol. I'm going to turn it over to Rob and have him tell you about that, because it's an example of where we're going in this field, where we're going to link up primary care medicine with addiction treatment. And it's time for those to be integrated. We've too long been on the sidelines of health care, and it's time to change that. And I'm very excited about what we're doing there and the promise it holds for many patients. So, Rob?
Thank you, Ray, and thank you, Randy, and the others. About 6 months ago, Ray invited me to come to Gosnell and head up the medication-assisted / Vivitrol sobriety maintenance program. There are 4 drugs that are FDA approved for sobriety maintenance in opioid addiction. 2 of them are Suboxone and Methadone. That makes up 98.5% of the drugs. And 2 of them are non-opiates. One is naltrexone, which is an oral once-a-day preparation, and the other is an injectable long-acting naltrexone, which is Vivitrol. Vivitrol is an injection that lasts approximately 4 weeks. In the opiate addict, cravings are certainly a large percent of the reasons for relapse. And especially after new onset sobriety, depending on what type of detox protocol is used, a patient has some pretty significant compulsions to use opiates. Naltrexone and Vivitrol bind to specific receptors in the brain, opiate receptors, and they block the ability of opiates to bind to those same receptors. So they block the ability of an individual to be able to get high from an opiate or an opioid, and probably more importantly, they control the cravings. As we've all spoken about it, the opioid epidemic probably, at least over the last 15 to 20 years, was brought on by OxyContin in the mid-90s. And up until the mid-90s, till approximately just under 2 years ago, it didn't dawn on anybody that you could crush OxyContin, and instead of get the oxycodone over a time of 24 hours or so, you could get it all at once. It was a drug sort of created for acute and chronic pain, but if a mad scientist was to create it in the laboratory to create something that would get people addicted to opiates as quickly as possible, they would come up with a formulation pretty similar to OxyContin. Once it finally dawned on everybody to put a buffer into the OxyContin so that it could not be crushed, sniffed, or injected, only taken via oral, Perk 30s, which is a very high dose of oxycodone, became the opiate du jour in our community and many other communities. You know, back when I started my medical training and I started out as a surgeon, if we did major surgery on somebody, we might prescribe them 1 to 2 standard Percocet 5s every 4 to 6 hours. That's 10 milligrams of oxycodone every 4 to 6 hours. That was just fine for 99% of patients. For patients that had chronic pain, that had malignancies, that had severe pain-related issues, there were other drugs that were probably much better than oxycodone or hydrocodone, such as morphine or Dilaudid, and then other formulations of drugs like fentanyl, which came in patch forms. Oxycodone 30, oxycodone 15 is really a dose that is far too great for 99% of patients. The only ones that benefit from oxycodone 30s, quite honestly, are patients that are addicted to opiates. And our young people take them by the handful, anywhere from 3 to 4 to 5 to 10 to 20. That is far and away just a ridiculous dose of oxycodone, and really is far and away too much of a dose of oxycodone for pain control alone. Indeed, most of the patients I see, at least 80% of them, did not start their opiate use because of chronic pain. They may have had mental anguish, but they didn't have chronic pain. They started off socially, and I have 2 of my 4 kids are here in the audience, and they're of high school age. And if I told them to go back into this auditorium when it was full and look around them, in front of them, behind them, to the left of them, to the right of them, I bet 2/3 of the individuals they would see are on some sort of addictive medication or addictive substance or some sort of chemical, whether that be alcohol, tobacco, marijuana, or opiates, cocaine, and others. Most of them today get started very young. We need to be educating our kids in middle school. Just like we're educating our kids about sex, we need to be educating them about prescription drug abuse and about addiction in general. As many of us have said before, addiction is a chronic brain disease. You probably have it when you're born, it's genetically predetermined. You don't find out till at some point in your life what you're addicted to. That addiction could be a chemical like an opioid, or could be a chemical like alcohol. It could be nicotine, it could be marijuana. It could be a non-chemical addiction, such as hoarding or spending or gambling or sex. In the brain, it's all the same. It's based around the amygdala in the brain, which is that very reptilian part of our brain that controls fight or flight. It controls our desire to feed, our desire to procreate, our desire to drink water, our basic primal desires. And many of us have various different types of addiction. We have to recognize that we need to educate our children when they are young, before they're even teenagers. Prevention goes a very long way for this disease. I see probably 70 or 80% of the patients I see are under the age of 30, and probably 50% of those are under the age of 20. Very few are addicted to pain medicine for chronic pain. So we use the drug called Vivitrol. We see a person initially every single day We do objective testing, quantitative urine testing for many different drugs, many different chemicals of abuse. And we track the amount of those chemicals that are in somebody's urine over a period of days and then weeks. We treat them until they are completely free of opiates, and then we start them on the oral medicine naltrexone. As soon as they've been on the naltrexone for several days, actually on the first day we see them, we start the paperwork to get the Vivitrol paid for by their insurance companies. About 99% of the insurance companies in this state will pay for Vivitrol. It's an injection that costs about $1,100, but as I said, 99% of the insurance companies in the state pay for it. Once they're on Vivitrol, we still see them weekly. We combine a primary care model with a behavioral care model. This is a disease where at least 80%, if not more, have what we call comorbid mental health issues. They have depression, they have bipolar disorder, they have attention deficit, attention ADHD and ADD, they have post-traumatic stress disorder, they have obsessive compulsive disorder. If you don't take care of the entire patient, both mentally and physically, you have very little chance of getting their disease of addiction under remission. We see them, we never stop seeing them. This is a lifelong illness. It doesn't go away, it doesn't go on vacation. We basically want to commit to seeing these individuals for the rest of their lives. Even once they are stable, we continue to see them at least every 2 weeks. This is pretty much unlike just about any other chronic illness out there, where once you're stable, even if things are not perfect, we might see you every 3 months, every 4 months. With addiction, every 3 and 4 months is just too far between. We're very passionate about our patients. We see anywhere from 15 to 20 patients a day. If the patients don't show up, we call them. If we don't get the patients, we call their sober support people, which are usually members of their family. It's a family illness as well as an individual illness. The entire family is devastated by this illness. And the entire family has to be involved in order for somebody to do well in this illness. You can't just isolate. And if I hear from a patient that they want to exclude members of their family, that's usually not a good thing. Because generally, if they're doing well, they have no desire to hold anything back from their families. It's when they've relapsed or are thinking about relapse, that's when they don't want their families to know. Thank you.
Thank you, Doctor. When I was looking the other way, David Sullivan came in. He's on the end of the table here. One of my cohorts in the House of Representatives from Fall River. Thank you very much, David. Would you like to take a couple of minutes to say something on behalf of yourself and the committee?
It was my GPS. I just want people to know that's why I was late. The risk of speaking towards the end of this is that there is probably so many good things that have been said, so I'm just sort of going to speak from what my experiences and on the committee, which I just want to compliment my chairs. I think they're doing a tremendous job, and the challenges that we encounter on the particular committee of mental health and substance abuse. First of all, when we look at the state budget and we look at the revenues that have declined over the years, when we start seeing 9C cuts and the depletion for services, the first things that go are the discretionary ends of the budget. And mental health, substance abuse certainly do fall in that. DPH has had their challenges. I come from Fall River, and I do want to talk a little bit about the prescription drug abuse and the problem as to how it impacts in Fall River. We do see quite a bit of it. Unfortunately, in Fall River, which has got its economic challenges, what ends up happening in Fall River is that folks are in our region, folks will start off with let's take, for instance, the OxyContin, but end up being on heroin because of the lower price of the heroin. So they start and they get hit with the because of the availability of the prescription medications addiction and have that addiction, but can no longer afford it, and we end up having a high heroin addiction because it's made and it's much more affordable for people. A couple of the things, I was just taking some notes, and I hope I'm not being redundant. I do want to reemphasize the issue of stigma related to addiction. Addiction, the stigma is a major challenge with this. Addiction is a physical illness. We need to be able to provide the services that are going to make a difference, and I think that's really important. When we talk about stigma and the causes of these addictions, I also look at other things that we're talking about that go along with that, including things like lack of housing, lack of employment, things that actually lead people into either relapsing, or, and I know someone didn't like that word relapse, but into relapsing or into actually getting involved with drugs for the first time. I was also taken back, one of the gentlemen, the doctor I think, was talked about 98 cents of the substance abuse or the money is spent on consequences for addiction. And I just find that to be appalling. And I got to say that that's actually the first time I ever heard that. And boy, I'll tell you, that really sort of woke me up. Important things that we need. I've talked on many occasions about things that are important. I think our early intervention and screening, prevention services, acute treatment services. I, as a representative, oftentimes will get a challenge of someone calling in or calling for constituent services and trying to help someone to get into some type of a treatment, whether it be inpatient or outpatient. And sometimes I find that to be a challenge, but I know everybody is trying to pull together and do the best they can with the resources available. Youth intervention programs are very important, as well as young adult case management. One of the things that I've always emphasized or talked about is the importance of relapse prevention, and I talk about that as part of the step-down treatment. People either coming out of jail or out of inpatient settings, that we need to make sure that they're able to be educated and to help themselves, not only to have the support services, but to make those judgments, to set a strategy as to how they can prevent relapse for themselves. And I always use as a good example of that is, you know, if someone's been discharged from a hospital or has come out of jail and because of an addiction issue and has got a job, and the one thing that they can do is they can strategize maybe perhaps how they're walking home from their employment. They want to stay away from the people that are going to be making drugs available to them. Sometimes it can be just as simple as just walking home a different way and making sure that you're going to avoid those people that are going to present a temptation or cause the problems. Massachusetts ranks high in different areas. I see that in the state rankings that past year of use of cocaine, alcohol use. I heard alcohol was mentioned. Alcohol continues to be a tremendous problem, and also past use of dependence on abuse of illicit drugs and alcohol, and basically the use of prescription drugs for non-medical uses as well. I'm glad to be here. I'm glad to be hearing the discussion. It's ringing a bell that I've heard many times over. The challenges that I see ahead of us is to make sure that we can continue to provide those services and to balance what we have available for us in state revenues. When we're looking what's happening on the federal end of it, we know that there are cuts on the federal end, and that's going to have an impact on our budget as well. So the battle goes on, and we continue to do the best we can. My compliments to our chairs on the committee, and I want to say thank you to them. And I'm glad to be a proud member of the Committee on Mental Health and Substance Abuse.
Thank you, Representative. You framed up a couple of things here very well. One of the discussions that we were having in Representative Malia's office just a few weeks ago was, how do we get across to the legislature that spending money in the right place will save us money in the long run and be much, much more effective than how we're doing it now, and I appreciate that you bring that up. Also, you frame the situation about how do people get help coming out of incarceration, and for that we have the sheriff here, Jim Cummings, and Dr. Stephen Dakota, and RN Jessica Gallagher to talk about the pilot program that is just about to get started at the Barnstable County Correctional Facility.
Well, thank you, Randy, and I certainly want to thank Senator Keenan, Representative Malia, and Representative Sullivan for the good work you're doing with this committee. I hope the legislation that was passed in the Senate moves through the House quickly and becomes law. I speak to our police officers, our agents in the Drug Task Force. I know Chief Wacker's here, and I'm sure he can attest to this as well. What they're telling me now is here on the Cape that about 90% of their caseload now has to do with pharmaceuticals, pharmaceutical opiates. It's no more heroin and cocaine, it's all pharmaceuticals. So there is a problem with this, and the problem becomes mine when there's no one else, or everything else has failed. That's when they get sent to me. That's when they come to jail. And our average sentence is about 8 months, and everyone expects, once they get there, it's a very sick population. We get a very sick population that gets sent into jail. And of course, once they get there, within the first month or so, they're sober and they're straight, and they want us to fix them the rest of the way. And we put forth our best effort, and all my brother and sister sheriff across the Commonwealth do as well, trying to rehabilitate the folks in the time we have them. We have a couple of very strong substance abuse programs. One is the RSAT program, which is a residential substance abuse treatment program. And we also have a SHOC program, which is another substance abuse treatment program. And these are high-intensity programs. I mean, it's basically all day and some of the night. And all they're doing is being counseled and educated and helped during this process. And one of our most successful programs is the GED program. We probably, since we moved up to Bourne in the new correctional facility, we've given about 450 GEDs. And the people who leave us with a GED, most likely we're not going to see them again. So it just shows how important education is to this. And that goes along with the drug problem as well. About 80% of the folks who are sent to jail have some issue with drugs or alcohol. About 15% of the folks who are sent to jail have some type of issue with mental health. So I say all the time, if I could get 80% of the folks to stay away from drugs and alcohol, and 15% to take their medication, we could probably close the place down and go home. But I don't think that's going to happen. So while we have the folks for these 8 months, I mean, it's a good opportunity for us to get them sober, straight, on the right track, and give them the education they need, and build that foundation so that when they leave the facility, they'll at least be partway there. But as the representative said, if we keep sending them to jail and then releasing them, and they go right back to the same old issues they had when they come in, we're going to see them again. So right now, when somebody leaves our facility, they have health insurance. Hopefully we can find them housing. A job is very important. Tough market to find the jobs, but we're still working at it, and we have a couple of ongoing programs with the local Chamber of Commerces and things like that to try to get them jobs. And we also have them leave with a plan relative to either their mental health issues or their addiction issues, so that they can stay on that track. And a new program that we're going to do, it's a pilot, and you heard a little bit about Vivitrol, and we're going to try to incorporate that into our release strategy. And I'll have and again, because these folks are so sick when we get them, I have a doctor, Dr. Steve Dakota, who is a full-time physician at the correctional facility, and we have a full-time nursing staff at 24/7, 365. So, we're certainly putting forth our best effort to make these people leave our facility and do a productive life, and we think that this Vivitrol program is going to maybe help us do that. And it's certainly isn't a magic pill. I mean, it's like the weight loss thing. They might tell you to take the pill, but you still got to exercise and watch what you eat too. So I think Vivitrol is like that, but it has some advantages that we think will help folks stay in the right and narrow once they're released from the facility. So I'll give it to Dr. Dakota.
So I just wanted to get a little of background of what we actually do provide in the jail. And then Jess is going to give us some more information about what's happening with this Vivitrol program in conjunction with Gosnold. So as inmates come in, or patients come in off the streets, we have an intake done immediately by the nursing staff. They're really dedicated and excellent nursing staff who really gets a really good picture together of what the patients are coming in with. And it's at that point where it starts, where we find out what they're using, what they're doing, and it's done very delicately and in a way that makes them feel safe to tell us what they're doing in terms of using addicting substances. We get them some information right away, and they're seen within a week and sooner if needed by me or someone from the mental health staff to do a fairly comprehensive evaluation. For people that are staying there longer, there is definitely some didactic or classroom-based education available to them. Some groups, some volunteers from NA and AA come in as well, so that people can share their experiences. And there are some that would think that if a person with addiction is locked in a room or in a building for 6 months or 8 months or a year, that their cravings or their addiction or their being away from their drug of choice or their drink of choice, that all that would just recede into a memory, but it really does not. This, as others on this panel have said, this is a lifelong condition. And we're trying to move forward with this and other programs in conjunction with other community-based organizations to treat it as a lifelong condition that requires ongoing care that starts inside the jail and continues afterwards. So let me pass on to Jess, who will describe more about what we're doing.
As has been mentioned, when substance abusers are released from incarceration, they're at very high risk for relapse. With that, there's a very high risk for them recommitting drug-related crimes and thus ending up with us again, reincarceration. It's a revolving door that we're seeing at facilities all over the state, actually. And as had been said before, a common belief is that if these people are in jail for a extended period of time, they're sober, why would they need addiction treatment still on the way out? And as has been stated as well, it's a lifelong illness. And what we're seeing a lot is when inmates, prior to their release, they'll report that they're having dreams of using again, their cravings spike when they know the date's coming up. So it's almost like their addiction is revving up again before they walk out the door. Us treating with Vivitrol upon release is appropriate for many reasons. One being that the Vivitrol injection, you need to be there needs to be an absence of opioid medications in your system for 7 to 10 days prior to the first injection. As you can imagine, opioid abusers, this is very difficult to do without any support, 7 to 10 days with nothing before they can start the treatment. In the corrections community, this barrier is not there because they haven't been able to use because of them being incarcerated. So in a lot of ways, the corrections setting makes a great kickoff point for their treatment with Vivitrol. Our pre-release pilot program process begins with an individual assessment of each inmate. Dr. Dakota and I meet with the inmate and discuss a couple things, basically trying to get a good feel about where their motivation level is, their willingness for change, and also their commitment to a comprehensive treatment plan, not just the medication. They need to be really willing to go to counseling and groups because it's not just going to work with the medication, and we really reiterate that to them. We plan to give the first injection of Vivitrol approximately 5 days before release. After you give the first injection, it peaks at 2 to 3 days after that injection. So we really want them we want to allow them to walk out the doors with an opioid blocker on board already. What we found is even if we were trying to refer them very quickly to Gosnold Centerville, and they've worked with us very well of getting people in there right away, but somewhere between Bourne and Centerville, they don't always make it. Believe it or not, just that car ride, probably depending on who they picks them up, or, it's just a very strong addiction. And so with us giving it to them before they walk out the door even, it gives them a much better chance for follow-up care at some of these clinics. And we believe we're really going on the belief that medication-assisted recovery is medication-assisted. It is not medication recovery. They have to be willing to go to counseling and do some of the work beyond that, because it just won't last with just the medication. As I said, we're currently working with Gosnold Centerville's Vivitrol program on collaboration of care, so that after we give, after we give the first shot, they can follow up with treatment there, receive counseling services, group therapy, and just encouragement to go to go to meetings, kind of a home base for their treatment after they leave. We're also collaborating with a lot of the other community health centers on the Cape, working out how they're going to take in some other patients after they leave. It'd be really beneficial to have a greater number of sites all over the Cape in different geographical areas, such as the Outer Cape, down in Hyannis and Duffy, and there's a bunch of sites for the Community Health Center of Cape Cod. As the name of the program suggests, we are in the pilot stage, so that means we're basically really hoping that we can get some good results from this. But with a pilot program comes us selecting outcome measures so that we can look at how successful the program is, and look at continuing it in the future beyond the pilot stage. Some of the outcome measures we're looking at assessing is their retention in outpatient therapy, how long they're going and following up with these clinics that they're referred to afterwards, if they're providing negative tox screens, and basically if they're not coming back to Barnstable County, if we're not seeing them reincarcerated. We hope that providing these inmates with this immediate and effective substance abuse treatment will benefit our community in many ways. First of all, decreasing the number of opioid-related deaths that we're seeing, a decrease in the crowdings of ERs for opiate-related overdoses and med-seeking behaviors, a reduction in crime that's drug-related, and much of our crime is drug-related, and also a decrease in the spread of disease that is relating to IV drug use. Hepatitis C is quite prevalent among our IV drug users, especially on the Cape. And with this, we're hoping to cut down on those rates as well. Thank you.
Lastly, I would like to have Lisa Murphy talk about parents supporting parents, the people out here in the audience wearing your shirts. Thank you very much for doing that. And how people can get a hold of the group, when do you meet, and so I'll turn it over to you. Thank you.
Thank you, Randy, for inviting me and the group.
Pull the mic close to you.
Oh, sorry. Thank you for inviting me and the group. We appreciate it, and we appreciate all the hard work all of you are doing to help save our children and help save us as well. I started this group October 4th, 2010. My daughter at that time had been 4.5 years in recovery. I decided to start it when I started seeing more children in the paper that were dying of opiate addiction. I started getting calls from parents on the phone saying, Lisa, we heard that your daughter's in recovery. How did you do it? And I would tell them I didn't do it, she did it, but I assisted her along the way. So we decided to start this group. We didn't know how many people were going to come. The Boys and Girls Club of Mashpee offered the space. The very first night we had our group, we had already outgrown the space that was given to us. And from there, we moved over to the Mashpee Senior Center. We run every Monday night, except for holidays. We have a good core group of parents who are loving and caring, and not very long ago they had children in these schools, that their children were high-achieving students, their children were the football players at Sandwich High School, Mashpee High School cheerleaders from all across the Cape. And at some point in their lives, their children made a bad decision. And many people make bad decisions, poor choices. They made a poor choice. And drugs ended up in their hands. And within a couple of weeks, they became addicted to drugs. And a lot of these children will tell you today that for the very first time, they felt normal when they took those pills, just like my daughter did. My daughter was a high-achieving student in Mashpee High School, played varsity basketball, and I had no idea that when I took her to have 6 teeth out, that Percocets were opiates. I wasn't counseled on them, and I should have been. I left them on the counter for her to take those pills and left her responsible for them, thinking she was going to take them as she was supposed to take them. I had no idea that within 2 weeks she was going to become addicted to them, just like many other parents. And when their children are playing sports and they've gotten broken bones, the same thing has happened to many of them. They're good parents and they're loving parents, and they've been stigmatized as well. We want the best for our children, like every parent does want. And so when we find our child is addicted to drugs, we run for help for them. We want to do everything we can to help them. When we started this meeting, we started discussing ways in which we could try to get our children treated, because some insurance companies weren't paying for long-term treatment for our children. When our children went to see if they could get Vivitrol to help them, our insurance companies were saying you needed a prior approval for Vivitrol, but they didn't need a prior approval for Percocet. It wasn't making any sense to us. We grapple with a lot of these ideas that come around. When we're sitting talking about passing these bills and who's going to pay for them, and how our state's going to come up with the money when we're already crippled financial situations, then I say let's take a look at that again, because it's not just the parents' responsibility, and it's not just all these agencies' responsibility, but there's a pharmaceutical company that's involved here, and they have contributed to this addiction, and they knowingly and irresponsibly gave out those prescriptions with kickbacks to doctors in emergency rooms. And that's something we need to take a look at, because they should be helping paying for the treatment and the education for these children. These are the ideas that we roll around with in our group. And at the same time, we are grappling with our own children's addiction, from active addiction to recovery. The average age of the children in our group range from 16 to 24, some a little bit older. The newest members of our group, their children are 14 and 15 years old. Can you imagine 14 and 15 years old? I think we've come a long way, and we have a long way to go. And I think we can get there if we work together. Thank you.
Thank you for that. I have here many, many questions. So we're coming close to the end of this public forum, so I'm going to make an executive decision here. I will write up and send all of these questions to the entire panel. And over the next week or so, we'll get responses back from the panel. So if you are on the email list that you can sign up for outside for the mental health and substance abuse email list, then I will get that back to you. For the people who are watching on public access TV or a replay of this, you can find that list of the 3 committees that I serve on, this one being the mental health and substance abuse, at randyhuntstaterep.com. You can sign up for that email list and get these answers when we send those out. It's very important that we keep the communication lines going, And what I find is the people that are on the list currently are ones that we communicate back and forth with all the time, and it's very useful. There's no political email that goes out, no fundraisers, no anything like that. Only business of this committee do we talk about on that email list. I thank everybody on the panel for being here tonight and everybody who's come out and given us a couple of hours on the Monday night. Thank you and good night.